Welcome to the AUA's educational program on Defendants for Medicare and Medicaid Services 2018 Merit-Based Incentive Payment System, or MIPS. Thank you for taking time out of your busy day to join us. I am Sonia Fashola with the AUA, and joining me are my AUA colleagues, Brooke Murphy and Jennifer Birch, as well as Dr. Barbara Connors and Patrick Hamilton with CMS. Before we begin, let me go over a few housekeeping items. All attendee lines will be placed on mute throughout today's webinar. If you wish to submit questions, please type it into the question box. We will answer questions as time allows at the end of the presentation. Today's session is being recorded. The presentation, as well as all the answers to all submitted questions, will be posted on the AUA's website. All attendees will be notified when this information has been posted. Today's presentation will focus on the 2018 MIPS program. If you have questions regarding the 2018 program, we ask that you submit them at quality@auanet.org. Now, let me turn things over to Patrick to begin the webinar.
We'll wait a few moments.
Anybody on the line? I'm not hearing anything.
Patrick, this is Jennifer. Can you hear us? Patrick?
Yes.
Okay, you're live.
Patrick? Patrick, can you hear us?
Okay. So we apologize. It might be a moment before Patrick gets back on the line. It'll just be a second, and we appreciate your patience. Thank you very much.
Hi, this is Patrick Hamilton. Can you hear me now?
Hi, Patrick. You're back on the line. Thank you. We'll get your
So
slides
sorry about
back.
that. I'm not sure what happened. Everything went completely quiet, and I wasn't sure if I was disconnected, and sure enough, I was. So
Okay.
let me just go ahead and start showing my presentation. Let me know that you can see it.
We can see your slides.
Okay, so I'm going to...
All right, now they're full screen. Perfect.
Okay, great. My apologies, everyone. Thank you for having Dr. Connors and I here today for your webinar. We spoke with this group, I believe it was at the end of January, to talk about data submission requirements for the 2017 performance year. Hopefully, we were able to answer all of your questions. I know that there was a little bit of delay in getting some of the responses back. But today we're here to talk about participation in year 2 of the Quality Payment Program 2018. Some pretty significant changes that should be to the benefit of most, if not all of you, in terms of burden reduction and how we are trying to continue to ease clinicians into the program instead of doing a full throttle participate to the fullest extent as soon as possible. So as we go through the presentation, we're going to hopefully highlight for you how we are trying to reduce the burden for participation in 2018. For those of you who are not familiar, maybe you're just hearing of the Quality Payment Program for the first time. Quality Payment Program is what we are collectively calling both the Merit-Based Incentive Payment System, or MIPS, and Advanced Alternative Payment Models, or Advanced APMs. And this all started from a piece of legislation that was passed by Congress by a bipartisan vote in 2015 called the Medicare Access and Chip Reauthorization Act, or MACRA. So a couple of different acronyms if you haven't heard them before. MACRA is the legislation. QPP is the Quality Payment Program, under which the Merit-Based Incentive Payment System, or MIPS, and Advanced APMs are housed. Moving on to slide 4, we're going to be focusing solely on the MIPS part of QPP for this call. When we were discussing what we are going to cover, because there is so much information. If we were to do a full webinar about the entirety of QPP, we could probably be here for a good half a day. But just given who the people in the audience are, Most, if not all of you, are participating in MIPS for 2017 and for 2018. So we're going to really focus on MIPS because that's really what you're going to be dealing with. We are planning to have more tailored presentations for advanced alternative payment models, both from the regional office, and also we are trying to get our central office to plan some national calls that focus on the APM side of the house. But today we're going to be talking about MIPS. MIPS actually is kind of a culmination or a larger umbrella under which aspects of our three previous legacy programs are now housed. So before MIPS came into fruition, 2017 was the first participation year, you may have been familiar with our former programs, those being the Physician Quality Reporting System, or PQRS, the Value-Based Payment Modifier, or VM, and also the Medicare Electronic Health Records Incentive Program for eligible professionals. You may also have heard that be referred to as meaningful use. One caveat that I always mention when we talk about the meaningful use program and how Medicare providers are transitioning into MIPS, if you are participating in the Medicaid incentive program, meaningful use, or if you are part of a hospital and the hospital is participating in meaningful use, the meaningful use program and the EHR program, meaningful use, they're the same thing. For Medicaid physicians and for hospitals, those programs are still in existence and they're still going on. When we're talking about the folding in of meaningful use into the new MIPS program, we were speaking strictly for eligible professionals, so those would be individuals or groups of professionals in the Medicare program. So just an important distinction to be made. The slide 5 shows the 4 performance categories for year 2018, and these performance categories have not changed. These were the categories that were finalized in the legislation and subsequent final rules. They are quality, cost improvement activities, and what we're now calling promoting interoperability. And we'll talk a little bit about that in a second. You see numbers underneath each of those categories, and if you add them up, they come to 100. So those numbers indicate the percentage or the portion of your final score, which is going to be on a scale of 0 to 100, fairly easy to understand, that each of the categories will consist. So for example, for 2018, quality counts for 50% of your score, cost counts for 10%, improvement activities counts for 15%, and promoting interoperability counts for 25%. You add them up, you get 100 points. We'll explain in a few slides exactly where you need to fall on that scale of 0 to 100 to determine what, if any, payment adjustments you will be receiving in 2020. So I mentioned that there were some things that have happened since the final rule was passed in 2017 that kind of laid the groundwork for what was going to be the program in 2018. And the biggest piece of legislation is the Bipartisan Budget Act of 2018. In addition to doing a lot of other stuff in the Medicare programs, it did some fairly significant stuff specifically in the quality payment program, again, that will be to the probably to the benefit of most, if not all, clinicians. So first of all, in terms of the payment adjustments, so you know that this program, if you perform above the threshold, you get an upward adjustment. If you fall below the threshold, you get a negative adjustment. And the way that the negative adjustment is calculated is based on your final score, and it's also based on the activity that you do in a certain time period. And for these programs, just like with our legacy programs, it's always a 2-year look-back period. So that means that 2019 is the first year in which a payment adjustment for MIPS will be assessed to Medicare clinicians. We look at the activity in 2017, so a 2-year look-back period. So 2017 activity dictates the 2019 adjustment. Your 2018 activity this year will dictate a 2020 payment adjustment. The change that was made is that the payment adjustments, either upward or downward, will now only be assessed to covered professional services under the Medicare physician fee schedule. So we used to say it was just anything that was paid or it was covered under the Medicare physician fee schedule, but they carved out anything that was not a covered professional service. And the big takeaway here is it really speaks to Part B drugs and other items and services that may be on the physician fee schedule but are not covered professional services. So that may have an impact if you are assessed an adjustment, either upward or downward, in terms of what that actual payment adjustment will be in terms of an impact to the revenue to your practice. Another big change as part of the BBA of 2018 was how we calculate the low volume threshold. I'm going to go into some detail in a few slides about what the low volume threshold is and how we determine whether or not a clinician meets the low volume threshold so that they would be exempt from participating in MIPS. And again, we are carving out Medicare Part B drugs and any other items that are not covered professional services, so that the new definition of the low volume threshold, and this might make a little more sense in a couple of slides, will now be based on Medicare Part B allowed charges for covered professional services, and the number of Medicare Part B beneficiaries who are furnished covered professional services. So when we talk about the threshold, we're always looking at charges and number of beneficiaries. So this is a fairly significant tweak to the definition. Again, this will probably enable more clinicians to be exempt from MIPS than otherwise could have been. On slide 8, the BBA also makes a few revisions to how we were going to implement the cost performance category in this year and actually in the next coming couple of years. So originally, the legislation that created the program, MACRA, had said that CMS had some flexibility in the first 2 years of the program to determine what the weight of the cost performance category would be. Now, if you remember on a couple of slides ago, the cost category in 2018 is 10%. And that was decided because the legislation originally said in 2019, cost must be 30% of the weight. So we made a decision. In 2017, cost counted for 0%, and there was a number of reasons why it was 0% in 2017. In 2018, we decided that we were going to gradually implement cost as part of the final score, so we decided it would count for 10% this year, thinking that in 2019 we were mandated to increase it to 30%. What the BBA has done, it says that CMS is no longer required to increase costs to 30% in 2019. It allows us to continue that gradual increase. And I believe by 2021 is when costs will have to be 30%. So we have a little bit more leeway. We have more time to get clinicians and practices familiar with what the cost measures are going to be. It also gives CMS more time to more adequately develop episode-based cost measures. We've had some tries in the past with the first year of the program. We also had some cost measures that were left over from the value-based payment modifier, but for various reasons, we decided that we did not want to continue with those. So right now, there are 2 cost measures. I'm going to go into a little bit more detail about cost in a few slides. But again, important to note that cost will not be 30% in 2019 as we thought so. And then also there's going to be additional flexibility that's going to be given to CMS to gradually increase the final threshold score. And when we get to the end of the presentation and talk about the final threshold score, again, that's that 0 to 100 scale. We have a little bit more flexibility of gradually increasing over the next couple of years of what that final threshold score has to be in order to avoid payment adjustments. So let's move on to slide 10, participation in 2018. A few changes. You can either participate as an individual, as a group, and a group as we have come to understand what a group is in these programs, as a virtual group, and I'll talk about virtual groups in detail, or in an alternative payment model. And if you're in an advanced alternative payment model, then there are extra benefits for that. Slide 12 shows the clinician types who are eligible to participate in 2018, and this is no change from the first year. The legislation said that for the first 2 years of participation, The clinicians that are the clinician types that are listed on slide 12 are the clinician types that would participate in the first 2 years. The legislation, the original legislation, gives CMS the opportunity to increase the clinician eligibility pool starting in 2019. We don't know if that's going to happen or not. Stay tuned for future rulemaking later on this year. So it's basically physicians, physician assistants, nurse practitioners, clinical nurse specialists, and certified registered nurse anesthetist. In addition to having to be a certain clinician type, you also have to surpass certain billing and or patient requirements. And this was a big change from year 1 to year 2. The inclusions for the first year is if you were billing more than $30,000 in services, or if you were seeing more than 100 beneficiaries, you had to meet both of those criteria in order to be included in the program. For year 2, we've increased those thresholds. So you have to be billing $90,000 or more, and again, in covered professional services, so no Part B drugs. And you must be seeing more than 200 Medicare Part B fee-for-service patients for whom you are providing covered professional services. So again, the inclusion is you have to meet both of those criteria. Now, how do we determine whether or not you are actually included based on your claims data? So we did not change the determination process in terms of eligibility from year 1 from year 2. So the first thing that we do is we verify, we do this through your PACOS enrollment data, that you are one of the MIPS eligible clinician types. So you're either a physician, a PA, an NP, a nurse specialist, or an anesthetist. After we verify that, we then do 2 determinations on your claims data. The first one for 2018 is we look at your fiscal year 2017 claims data to see if you meet both of those criteria that are listed here on slide 13. If you're billing more than $90,000 and you're seeing more than 200 patients, if you meet both of those criteria, then you are included. If you, on the first determination, meet the exemptions because you do not meet both of these criteria on slide 13, then you are deemed exempt from the program, even if at bullet point number 3, when the second determination is done after the participation, even if your claims data shows that on the second go round you did meet the criteria, your exemption carries over. So once you are exempt in the first determination, you're exempt from the year. You do not have to worry that CMS is going to come back to you in a year and said, oh, and by the way, you do have to participate, and it's September in 2018. So it's going to be quite a hardship. So that's not going to happen. Slide 15 has the payment adjustment information for both 2019 and 2020. So you'll see in the left-hand side, that was for the transition year for 2017. The threshold score, and we talked about the threshold score, for on the scale of 0 to 100 for the first year, in order to avoid any negative payment adjustment, you had to score a minimum of 3. So again, that's on a scale of 0 to 100. If you got a 3, then you were not dinged. You were not going to get a payment adjustment. Now, the higher that you score over 3, the higher possible upward adjustment that you can get. If you score higher than 70, then you are considered an exceptional performer, and there is a separate pot of money that was set aside by Congress to reward exceptional performers. For this performance year in 2018, you'll see that we again are gradually increasing the threshold score. So it's not going to be 3, it's 15. There are still a number of ways that you can achieve a score of 15, even if you are not fully participating, meaning that you are not submitting all of the data in all of the performance categories that you would need to in order to be considered a full participant. When I said that CMS is going to have additional leeway in terms of that threshold score, that's what I'm talking about. So if you see on the right-hand side in the green where it says 15 points, you can probably expect over the next couple of years that that is going to gradually increase. The legislation states that in a given year, once we finish the transition and everybody is fully engaged into MIPS, for a given performance year, that threshold score, so 3 or 15, is actually going to be either the mean or the median of all clinicians' performances in a given past performance period. That has not been determined what that performance period will be necessarily, but to give you an idea, when we did the proposed rule, when this program first started, when we were writing our examples for a typical, quote unquote, typical year, the threshold score that we talked about was in the neighborhood of 60. So the fact that we made it 3 for the first year, 15 for the second year, you can see that we are trying to do as much as we can to gradually bring clinicians on board while still making the program meaningful for those who are able to participate more fully right away. So we talked about who is included, who is exempt. There is no change in the exemption criteria, in that if you are newly enrolled in Medicare this year, then you are exempt for 2018. If you are significantly participating in an advanced APM, and again, on an APM presentation, we would go into more detail, then you would also be exempt from MIPS. And then we talked about the low volume threshold. Big thing to keep in mind here, in the middle box, we talk about the allowed charges for covered professional services being $90,000 or less, or you're seeing 200 or fewer Medicare Part B patients a year. That or is significant, because when I was talking to you about who was included, you had to meet both criteria. When we're talking about who is exempt, you only have to meet one criteria. And I believe that we have an example coming up in a few slides. So one question that we've been getting a lot in the agency is, does the $90,000 in Medicare Part B allowed charges for covered professional services under the fee schedule and 200 Medicare Part B beneficiaries who are furnished covered professional services under the PFS, physician fee schedule, also apply at the group level if my practice chooses group reporting? And the answer is yes. So the inclusion and the exclusion criteria are the same for both the individual and for the group, if the group so chooses to participate as a group. And here's the example that I was talking about on slide 19. So on the left-hand side, if we have 3 practitioners or 3 clinicians in a practice, so we're going to say that Dr. A billed more than $250,000, and we're going to assume that it's covered professional services. And he saw 210 patients. So you can see Dr. A met both of the criteria for inclusion. So as you can see, he is included in MIPS. Dr. B billed $100,000, but saw only 80 patients. Now he's exempt because he didn't meet both of the inclusion criteria, or conversely, he met just one of the exclusion criteria. The nurse practitioner billed $50,000 and saw 40 patients, so she met neither the inclusion criteria, so she is exempt from MIPS. However, let's say that this particular practice, for whatever reason, and there are reasons why they would want to participate as a group, they decided they want to participate as a group, pool their performance together, and be assessed at the tax identification number or the TIN level. As a group, if you add up the charges from Dr. A, Dr. B, and the NP, and the number of patients that all 3 saw, you would see that they exceed the $90,000 and they exceed the 200 patients. So even though 2 of them individually would be exempt individually, because they're choosing to be assessed as a group, the group is eligible as a group. So all of them would be included in MIPS. So new for 2018, actually this was new last year, but because of the timing, there really wasn't a whole lot of time for virtual groups really to get their act together and to do the election process that needed to be done. Virtual groups is a new concept for Medicare in terms of participation in these programs. We did not have virtual group reporting in PQRS and meaningful use, so this is something that's new. And again, if you have interest or if you're in a practice that may want to join a virtual group, we do have more information. We cut some of these slides down for time's sake. But the idea of a virtual group is that you are to be considered like a normal group would be considered, but you're not necessarily geographically in the same location. You may not even be in the same specialty, but for whatever reasons, you may have the opportunity, either as a solo practitioner or as a small group, to come together and to be assessed jointly across all the performance categories. So the way we define it is here on slide 21. A virtual group can be made up of solo practitioners, so individual clinicians, and groups of 10 or fewer eligible clinicians who come together virtually. And again, no matter what your specialty is, no matter where your location, to participate in MIPS for a performance period for that year. So in order to join or form a group, you have to be, like I said, either a solo practitioner, and you have to meet all of the criteria that we talked about. So you have to be one of the clinician types, and you have to meet the inclusion criteria in terms of your charges and the number of patients that you see. Or you can be a group, an actual group under 110 that has 10 or few eligible clinicians that exceed the low volume threshold. Slide 22 looks very busy, but if you look at it, it tells you exactly who can participate in a virtual group. So basically, we'll start on the left-hand side. So kind of like the aquamarine blue solo practitioner is eligible for MIPS. We'll just say that this person is a physician, so they can participate in a virtual group. And this person happens to be part of a traditional group that has 10 or fewer clinicians, and at least one of them is eligible for MIPS. So let's say that this physician, this blue physician, is with 9 other purple individuals that might be, I don't know, therapists or dietitians, audiologists. One of the clinician types that are not necessarily included in MIPS, but because he's part of a group, there is at least one that is MIPS eligible. They can be part of the virtual group. Who cannot participate in a virtual group? That's on the right-hand side. If you're a solo practitioner who's not eligible for any number of reasons that we talked about, if you're in a group that has no eligible MIPS or no eligible clinicians for MIPS, or if you have a group of 11 or more. So again, solo practitioners who are eligible and groups of 10 or fewer with at least one MIPS eligible clinician. And as you can see at the bottom, there's no limit to the size of the virtual group itself. So you can have 200 individual solo practitioners, all of whom are eligible for MIPS, to come together to form a virtual group. You can have 10 individual solo practitioners who are eligible, and you can have 6 groups that have 8 members each. They can all come together. We don't put a limit in terms of how big the actual virtual group is. The only limit is the size of the traditional group who can come together to form the virtual group. Generally, the policies that apply to the groups would apply to virtual groups. They will be able to use all the same submission mechanisms. All the clinicians within a TIN are part of the virtual group. There is an election process. There is an enumeration process that the virtual group will get a separate virtual group number. They are required to aggregate their scores across the virtual group for each performance category, and they will be assessed as a group. And again, there is an election process that we usually include, but for sake of time, we cut those slides out. If you think that this is something that you're interested in, you can reach out to us after the presentation, and we will be happy to point you in the direction for more information. So now we're going to go into the performance categories. I'm going to start with quality and cost, and then I'll hand it over to Dr. Connors, who will pick it up with improvement activities and interoperability. If you participated in the program last year, there are virtually no changes in terms of what needs to be submitted in terms of your data. So for example, for quality, yes, we did change quality last year. It was 60% because we had cost at 0. So we gave quality the 10% that cost would have had. So this year it's going to be 50% of your score. The requirement is still the same, that you have to select at least 6 individual measures, one of which should be an outcome measure. If there isn't an outcome measure that's available to you because of your scope of practice, then you can pick another high priority measure. So it's 6 measures. There are more than 270 from which to choose. Some of these small changes that were made: data completeness. So last year, only 50% for data completeness. It's 60% in 2018. So that means at least 60% of your cases or your patients that could have that measure reported needs to be reported in order to get credit. There is a 3-point floor for measures that are scored against a benchmark. So what that means, and this goes into a little bit more detail than we want to get into, but basically for your quality measures, your performance in an individual measure is scored on a scale of 0 to 10. Now, each quality measure has their own benchmark, so it's not uniform. So I can't say that if you had an 85% in one measure, that means you get an 8.5, because it could mean that you get a 7.6 on another measure just because of the skewing of the weights. Regardless, if a measure has a benchmark, and it would have a benchmark because we have historic data from a previous performance period against which to assess your performance, then the minimum amount of points that you can get is 3. So again, when you're choosing your quality measures, you want to probably choose measures that have benchmark data, because the minimum that you can score is a 3. There is going to be an additional high priority measures up to 10%. So there are bonuses available if you submit additional measures that are high priority or outcome. And then also there are bonuses that are available if you do end-to-end reporting. So basically using your EHR system to submit your data. We're also going to start phasing out what we're calling topped-out measures, and it's going to happen over a 4-year phasing out timeline. A measure is considered topped out if meaningful distinctions and improvement in performance can no longer be made. So there is a 4-year process. If a measure is deemed to have been topped out for 2 years, then they will start to go through this process where we basically phase out. And the reason why that's important is that if you are choosing measures, then you're going to possibly limit the number of points that you can get. So if you are reporting a measure that's deemed as being topped out, the highest score that you can get on that 0 to 10 scale for the individual measures is 7 points. It's also important because next year we're going to start scoring improvement in your quality score. And if you are choosing quality measures that are topped out, you're really giving yourself no ability to improve, because the very definition of a topped out measure is, everyone is performing at such a high level. There's no variability in scores. There's no way that you can improve. And in the end, it could be to your detriment to continue to choosing these measures. Slide 28 tells you what the 6 topped out measures for 2018 are. I believe that we will be publishing the topped out measures list most likely through rulemaking. My guess would be through the annual physician's fee schedule. Moving on to cost, we talked about cost in a little bit of detail a little bit earlier. I mentioned that it's going to be 10% in 2018. I also mentioned that the 10 episode-based measures that we had originally adopted for last year, they will not be used. A couple of things I did not mention about cost. There is no proactive data submission that you need to do for cost. What that means is, unlike quality, where you have to submit quality data, improvement activities, and the interoperability performance category, you don't have to submit anything for cost. CMS will do that assessment through administrative claims data. The 2 measures that are going to be used, I believe, are on slide 30. So we are going to be using Medicare spending per beneficiary and total per capita cost measures for Part A and Part B services. And these are the 2, I guess you can call them, standard cost measures that have been part of the value-based payment modifier program from its inception, and they will continue to be part of any cost category measures that are being included. We're also, and I think Dr. Connors probably will be mentioning feedback reports. After you submitted your 2017 data, you were able to access very preliminary information in terms of how you scored. We are hoping that after July 1st, your final reports will be available to you. Very important to go and get them, because all of the data, all the detailed data that basically generates your final score that's going to dictate whether or not you have the payment adjustment or going to be in that report. I bring this up now because even though cost is not going to be part of your score for 2017, the year that just ended, you are still going to see cost data in those reports. For 2018, the cost data is going to factor into your final score. So even though it's 0% for your performance for last year, very good idea once you get those reports that you look at your cost data because there could be the possibility that some of the numbers don't look right to you. And there will be a targeted review period after the release of the final reports where you can ask CMS to review the data that's contained in those reports. So with that, I'm going to turn it over to Dr. Connor. She's going to pick up on slide 31 with improvement activities. And Barbara, just let me know when you want me to advance the slides for you.
Sure. Thank you, Patrick. So we'll go into improvement activities now. I'll briefly reiterate the changes and the non-changes. So the basics for your improvement activity category is unchanged, 15% of the final score in 2018. We've added several activities, so we're up to 112 activities available for 2018. They're scored as have been in the first year in 2017, medium weight 10 points, high weight 20 points, and as it was last year, all you have to do is simply attest. However, there are other methods for you to report as well. There's no change in the number of activities that the eligible clinicians must report. However, in the spirit of reducing burden, we have several categories of eligible clinicians, such as those in small practices, which is 15 or less, practices in rural areas and HIPSA areas. They are only required to report on no more than 2 activities to achieve the highest score. If you're in a patient-centered medical home, we did finalize the term recognized as equivalent to the term certified as a patient-centered medical home or comparable specialty practice. And if the practice is a patient-centered medical home, then full credit is given to the entire practice as for the improvement activities. However, if you are in a virtual group, 50% of those practice sites within the TIN or TINs must be recognized as a patient-centered medical home for the TIN to receive full credit for the improvement activities in 2018. Next slide, please. So CMS's goal is to allow flexibility in performing the activities and to avoid complex reporting requirements. We are attempting to incentivize the use of health IT, and there are activities within the performance categories that also qualify for ACI performance category bonus, and I'll expand on that in a minute. For group reporting, only one MIPS eligible clinician in a TIN must perform the improvement activity for the entire TIN to receive the credit. For virtual reporting, only one MIPS eligible clinician in a virtual group must perform the improvement activity for the entire TIN to receive credit. And again, it's simple attestation. However, you can report through other methods. Now, some of the categories for improvement activities, such as ongoing care coordination, clinician and patient shared decision making, regularly using patient safety practices, expanding practice access, population management, care coordination, beneficiary engagement. They're all activities that clinicians do. When we first proposed the improvement activities, there was a great deal of confusion and even pushback simply because clinicians do this, but they haven't really organized their activities in the context of improving their practice. So let's say, for example, population management. For those urologic patients with chronic UTIs or renal lithiasis, that's a population of patients. How do you manage those patients, especially when they have an acute episode? That's an improvement activity, and that's what urologists do. Let's go on to the next slide. So for advancing care information, some of the basics are unchanged. ACI remains at 25% of the final score in 2018. It's comprised of base, performance, and bonus scores. And the purpose for ACI in the program is to promote patient engagement and electronic exchange of information using certified EHR technology. There's two sets of measures that are available. You can report 2018 ACI objective and measures if you have technology certified to the 2015 edition or a combination of the 2014 and 2015 edition. Additionally, you can report ACI transition objectives and measures if you have a combination of both years, 2015 or 2014. And we did receive a pre-webinar question to that effect, and I can repeat it at the end of the webinar. But again, if you have 2015, you can still report ACI transition objectives and measures. If you are only using the 2015, you do receive a 10% bonus for using only the 2015 edition. Let's go to the next slide. Some of you may have heard about the 21st Century Cures Act, where Congress has asked CMS to really look at clinician burden and burden across all providers. We did reweight the advancing care information performance category to 0 and reallocate that weight to the quality performance category for several reasons, including hospital-based MIPS eligible clinicians, ambulatory surgical center-based MIPS eligible clinicians, retroactive to 2017, nurse practitioners, PAs, clinical nurse specialists, CRNAs, and through an approved application, there's a new hardship exception for clinician practices with 15 or fewer clinicians if your system was decertified, as well as significant hardship exceptions. We will not apply the 5-year limit to those exceptions. And additionally, there's a first of the performance year for submission of those applications, and that would be on an annual basis. We also revised the definition of hospital-based MIPS eligible clinicians to include covered professional services on an off-campus outpatient hospital, and that's the place of service 19. The place of service 19, hospital services 21 modifier, on-campus outpatient hospital 22 modifier, ED 23 modifier, and ASC 24 modifiers. Those are the place of practice that we will reweight. Let's go on to the next slide. So let's talk a little bit about, in addition to the changes, some of the non-changes. So there's no change in non-patient facing criteria. If you're an individual and you have less than 100 patient facing encounters, or if your group has greater than 75% of NPIs billing under your group's TIN during a performance period labeled as patient-facing. There's no change to those two policies. However, as Patrick referenced before, we have new virtual groups, and they are, again, groups that have greater than 75% of NPIs within a virtual group during a performance period labeled as non-patient facing. Let's go on to the next slide. No change in hospital-based criteria. And again, we added for this year the off-campus outpatient hospital. Keep in mind that hospital-based clinicians, as well as those other categories, have their ACI performance category reweighted to 0. However, hospital-based clinicians are subject to MIPS if they exceed the low volume threshold and are still required to report the quality and improvement activity performance categories. Next slide, please. Similarly, for the ASC special status, we deemed it retroactive to 2017. The place of service, again, is code 24, but it's defined as a freestanding facility other than a physician's office where surgical and diagnostic services are provided. Now, many urologists perform cystoscopies in their offices, and they're not considered an ASC. So that distinction really has to be clear in the minds of everyone that's looking at how they're coding in their place of service and whether they believe they need to report that ACI information or not. If it is in fact an ASC, then again, their advancing care information performance categories reweighted to 0, but if those clinicians exceed the low volume threshold, they are still required to report the quality and improvement activity performance categories. Next slide, please. There's no change to the basic application of small, rural, and HPSA special status. Next slide, please. The special rules exist for the improvement activities performance categories. As I referenced before, for the groups of 15 or fewer eligible clinicians and solo practitioners, designated rural areas, and HPSAs. And the points for both medium weight and high weight activities are doubled for those groups. And as I said before, they only have to report 2 activities, improvement activities. Next slide, please. There's no change in the ACI performance category, automatic reweighting policy for MIPS eligible clinicians who are considered non-patient facing, hospital-based, ASC, as well as the other categories listed, the PAs, the NPs, the CRNAs, and clinical nurse specialists. Let's go on to the next slide. So how do you check your participation status? Thank you. If you want to check your participation status for MIPS, you can start by checking by looking under the NPI lookup tool on the qpp.cms.gov portal, which I hope that all of you on the call are familiar with. You can actually go in there and look at your final score for submission for the 2017. Those numbers may be tweaked a little bit in the event that we have benchmarks, but your score will not go down from the score that you have in there now, unless it's an exceptional or rare circumstance. We do not mail letters for this year. We will not mail letters, so if you're not sure, it's really important that you go in and check your status. So the first thing you do is enter your 10-digit NPI number. Let's go on to the next slide. So if you're included in MIPS, the screen below will pop up, and it lists the first review of performance year 2018 is now available. If you're exempt, you won't need to do anything else, and it's right there in front of you. It's one and done, and you don't have to do anything further. However, if you are included in MIPS, you can go down to the right-hand corner, the little green button, what can I do now? So let's go to the next slide. So there's several scenarios. So let's say on the left-hand side, the clinician's reporting as an individual. So if the clinicians billed Medicare for $90,000 or less, or provided care for 100 or fewer patients, then that clinician would be exempt. Additionally, if the clinician reports as a group and the group practice billed for 90 or less, then that clinician is exempt. However, if the clinician reports as an individual and doesn't meet the threshold, but is in the group and the practice has billed for more than 90,000 and provided care for more than 200 patients, the clinician's exempt at the individual level, but may need to participate if the TIN opts to report at the group level. Now, if the clinician reports as an individual and has billed Medicare more than 90,000 or participated in the care of more than 200 Medicare patients, or the practice has billed more than 90,000 and provided care for more than 200 patients, that clinician is included at both the individual and group level and need to participate. So the takeaway really for this slide is if the clinician is exempt but is in a group and the TIN is reporting as a group, and that group is required based on their billables and their patient number, that clinician may need to participate. Let's go to the next slide. So we don't have the lookup tool ready yet for APMs, but we will in the near future, and it will look almost identical to the MIPS lookup tool. Next slide, please. So there's still help and support out there. If you didn't take advantage of it last year and you realized when you were submitting your data that help would be helpful for you or the practice. If you're a smaller practice or a specialty practice, primary care and specialist physicians are working across the country with in the TCPI initiative. The practice transformation networks are available in all the states. If you're part of a large practice, then the Quinn QIOs are available. For small and solo practices, we have the SERVs contractors that are available. The QPP website has a tremendous amount of information. Hopefully, many of you have taken advantage of. We also have the service center available. We've received a lot of calls through the service center towards the end during the submission period. And because of the calls and the feedback we received, we did extend the submission by a few days because there were some snafus and hiccups with the portal. We also have, for those that are in APMs, the CMMI learning systems. Next slide, please. So I believe you already have the our contact information. If not, we can give it to you before we hang up. There were a couple other questions. One question was regarding some modifiers. I'm not sure whether we want to get into that now or we could answer on the end, but Patrick, I'll pass this back to you.
Yeah, we did get a few, as Barbara said, we did get a few questions. Will we have to submit full ACI in 2019 for 90 days or the full year? My understanding is that moving forward, improvement activities and the advancing care information or promoting interoperability, I think we're in the middle of deciding what we're going to call it, I believe is going to be for 90 days, but always keep an eye out on rulemaking as it pertains to QPP for any changes that were made. But I believe that in one of the rules that came out, the idea was that quality and cost would be assessed over the entire calendar year, whereas improvement activities and ACI would be for 90 days.